the screen?
Yes, sir.
Well, very good evening to all of you, and good morning and good afternoon to all others who are joining from rest part of the world. Today we have got two guest speakers. The first we have Dr. Alok Shetty, and the second guest speaker is Dr. Nazima Gangat. This webinar, as usual, is brought to you by Mumbai Hematology Group, supported by Novartis, Unipath, Lucien, and Nirvin Life Sciences, and very well managed by Perfect Square. I thank Team Novartis, Unipath, Lucien, and Nirvin, Mr. Yash, Mr. Kalpesh, and the team from Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speakers for the day, Dr. Alok Shetty from Mumbai and Dr. Nazima Gangat from USA. All our discussants were themselves very eminent hematologists as well as medical oncologists, and you participants for sparing your Saturday evening, morning, or afternoon from whichever part of the world you're logged in. Tomorrow, that is Sunday, 6th of July 2025, from 11:30 a.m. Indian Standard Time and 7 a.m. UK time, we have Dr. Sridhar Chaganti from University Hospital Birmingham, UK, speaking to us on an update on DLBCL from EHA and Lugano. Let me introduce our discussions for the day, and we have a galaxy of them here displayed in alphabetical order. I will stop for a while for you to have a look on all our discussions for the day. These are all our eminent hematologists all over the country. So these are our discussions for the day. Now it's a time to introduce our first speaker for the day. We have with us Dr. Alok Shetty from Tata Memorial Hospital, Mumbai. Let me introduce Dr. Alok Shetty to all of you. He is medical oncologist at the Adult Hematolymphoid Unit, Department of Medical Oncology at Tata Memorial Hospital, Mumbai. His current areas of interest include acute myeloid leukemia, supportive care in acute leukemia, MPNs, and low-grade lymphomas. He is currently involved in organizing the CML and MPN clinics at Tata Memorial Hospital, Mumbai, which aims at improving comprehensive care for these patients, and also in organizing various patient support group meetings for patients of MPNs in coordination with Friends of Max. Today he is going to lecture us on optimizing myelofibrosis management, early treatment with Ruxolitinib. I stop over here. Over to you, Dr. Alok Shetty.
Thank you, Dr. Amit, for the kind introduction. I will share. Can I share my screen?
Yes, please.
Yes. Okay. So what we have. Okay. I guess my screen is visible, I guess. Yeah.
Yes, it's visible. Okay. Perfect.
Okay. So good evening, everyone. So I think we'll be going through the optimizing the management of myelofibrosis using the only JAK inhibitor, I think, which is available to most of us currently, which is Ruxolitinib. My acknowledgements to the Novartis medical team for providing a large part of the slide deck. So as we know, myelofibrosis is one of the most common myeloproliferative disorder that we encounter. Though in comparison to all hematological malignancies, it's relatively rare. But amongst the myeloproliferative disorders, it still remains one of the most common pH negative chronic myeloproliferative disorder that we come across. It's characterized by a constellation of symptoms, mainly constitutional symptoms of weight loss, fever, along with splenomegaly and progressive cytopenias with needing transfusion requirements over a period of time. So this is what characterizes myelofibrosis, as we all know. So without going much ado, the large part of the treatment of myelofibrosis is currently based on risk stratification using various scores over time, with molecular factors being incorporated into these scoring systems more and more often. And with availability of NGS and other mutation parameters, this is something that is being incorporated. However, still a large part of the risk scoring is based on simple parameters such as anemia, splenomegaly, the presence of peripheral blood blasts, and constitutional symptoms is what still decides the risk category that these patients would fall into. A small subset of patients would probably fall into the low risk or an intermediate 1 risk, where they may be minimally symptomatic or asymptomatic and may just need observation or symptom-guided management. However, a significant number of our patients fall into the intermediate 2 and high risk or very high risk group requiring some form of therapy. If, however, even in the current scenario or in the current era, myelofibrosis remains largely incurable disease, with the only curative option being allogeneic stem cell transplant. But a significant number of these patients are elderly with median age being more than 60 years of age, and making transplant a challenge in itself. And like in our situation, like in our setting, transplant is going to be the feasibility of transplant is challenging for a large number of our patients. So in that setting is where in these patients of intermediate and high risk patients, one needs to consider other therapy, which is with JAK inhibitors, which has been a game changer in this situation. So as we can see, so the significant approval for JAK inhibitors is for intermediate risk and in high risk or very high risk patients. If either prior to this can be used prior to transplant also, and in patients who are transplant ineligible. For many years, the only JAK inhibitor available, of course, was Ruxolitinib, with more recently other JAK inhibitors being made available, more so for patients who probably have thrombocytopenia or anemia to begin with, which could be either momelotinib or pacritinib, and other fedratinib being approved in the front line. So in the front line, we have Ruxolitinib and fedratinib, and in patients with anemia and thrombocytopenia, momelotinib and pacritinib, and in second line, these drugs which can be used after Ruxolitinib failure. Though, going on to Ruxolitinib per se. So Ruxolitinib, which was discovered almost around and studied almost around a decade ago, it targets the JAK STAT pathway. So as we know, it is the JAK STAT pathway which plays the major role in the pathogenesis of myelofibrosis and its various constitutional symptoms. Almost 70 to 80% of patients with primary myelofibrosis have mutations either in the JAK 2V607F gene or in the MPL gene or in the CALR gene. So that is the main driver mutations in most of these patients. In remaining 20 to 30% of patients, they may be triple negative, though however have mutations in other epigenetic genes or other genes which control the these myeloid proliferation. It is this JAK pathway that the JAK inhibitors target, thereby resulting in reduced clonal expansion, reduced inflammatory signaling, and thereby improvement of symptoms. However, this comes with a side adverse effect or an accompanying adverse effect of cytopenias, where either anemia and thrombocytopenia could set in because it affects the thrombopoietin receptor pathway or the erythropoietin receptor pathway. So that is, and again, there may be a risk of infections, or small risk of infections that can be sometimes seen as part of the adverse effect. So this is the mechanism of the JAK inhibitors. So, like we know that the dosing of Ruxolitinib is dependent on the platelet counts at the initiation of therapy. So in the initial studies that were done, which was the phase 3 confirmed studies, the only patients who were allowed were patients who had more than 1 lakh counts. So that was how the initial phase 3 comfort studies were done. And in this, the dosing of the patient or dosing of Ruxolitinib was based on the initial platelet count of the patient. To this date, however, though, with time, studies were later done for patients with platelet count of 50,000 to 1 lakh. However, till now, Ruxolitinib has not been studied for patients who have platelet count of less than 50 lakh, and Ruxolitinib is not routinely recommended in these patients. Over time, the dose of Ruxolitinib has to be titrated with the monitoring of the platelet count, and the dose may be increased, or the recommended dose increases by around 5 mg twice daily to a maximum of 20 mg twice daily, based on the monitoring of CBC. And this should not be done. Initially, it should not be done after 4 weeks. That is at least after a month of starting therapy, and later, not earlier than 2 weeks rather. So, and it is suggested, the recommendation is to, optimize dose to the maximum tolerated dose for an optimal or for the best efficacious outcomes. So I'll be discussing on two parts. The first is in patients who have platelet count of more than 1 lakh to begin with. And the next part would be in patients who have platelet count of 50,000 to 1 lakh to begin with. So like I said, so the COMFORT trial, we should remember, included patients who had platelet counts of more than 1 lakh, who were belonging to the intermediate 2 or high risk category, who had a palpable spleen, and who were actually initially who were JAK2 positive or negative, and it was a placebo controlled trial. The experience, or with time, it is shown that the most patients treated with ruxolitinib would probably tolerate a dose of 10 mg twice daily or above. So for example, in the COMFORT one, the majority of patients originally randomized to 15 mg and 20 mg BD had their doses titrated by week 24, that is probably by around 6 months, to a dose of more than 10 mg BD, which remains stable with long-term therapy. That is, patients are able to tolerate a dose of more than 10 mg twice daily to up to 20 mg twice daily, and the dose usually is titrated by around 6 months of starting therapy. The also it is noted that the this dose optimization is quite essential to improve outcomes. That is, larger improvements in spleen volume and symptoms were observed in ruxolitinib treated patients who received more than 10 mg compared to those with who received lower doses. This is a sort of like a deterrent to many times we would try to use lower doses in some of these patients. But by going by data, that is not a good practice to do, or not a suggested recommendation. So also it was noted that the patients who achieved a reduction in splenic volume had from baseline had a good, relatively much better prognosis in those who had, and this was more in patients who had received their optimal or higher doses. So the challenge with ruxolitinib becomes the twofold challenge of anemia and thrombocytopenia. So what is so one needs to carefully optimize the dose and use supportive care at this point of time to maintain an adequate dosing of ruxolitinib, which would thereby improve outcomes. So like I had said previously, most this anemia and thrombocytopenia and an expected adverse effect of the JAK inhibitors, mainly because of the pathway that it inhibits, with the reported adverse events being, the anemia and thrombocytopenia being to the range of at least more than 80% in most of this patients. Though theoretically, in practice, we'll see that many times it's very difficult to differentiate whether the anemia that is occurring is part of the disease or it's part of ruxolitinib. So would require close clinical follow-up and decision making. Uh, One thing to remember is that there is often a drop of the hemoglobin in the initial 12 weeks, that is the first 3 months of therapy. What is expected is a predictable decrease in hemoglobin often occurs. So that should not deter us and from continuing this therapy. And this is something that needs to be informed to the patients too while starting ruxolitinib. So in the initial 3 months, there's an expected fall in the hemoglobin, which usually stabilizes over time. So this predictable and temporary decrease in hemoglobin can be supported at that point of time with supportive care such as transfusion or probably use of erythropoietin stimulating agents like erythropoietin or darbepoetin that can be considered at that point of time. So this anemia in the initial period needs to be remembered. This worsening of anemia in the initial period. The Later, I mean, also what has been looked into in this cohort of patients is that the patients who have had this initial decline in hemoglobin, that has not had any impact on the outcomes overall. That is and it was actually seen that the patients who probably had this expected decline probably did slightly better than the patients who did not. Also, the platelet counts may usually decline in the first 2 to 3 weeks from their baseline values. And but however, and then this remains stable over the period of time. So there is an initial expected decline in platelet count also in the first 12 weeks, which gradually stabilizes. So with time, this dose will need to be monitored with the platelet count monitoring, with the goal of avoiding too many dose interruptions. But in the initial 12 weeks, there may be a higher chance that you may have to modify their doses based on their platelet count. Uh, so treatment, however, should be discontinued if the platelet counts fall less than 50,000, or if the ANC falls to less than 0.5 or less than 500. And after recovery, it may be restart at the lower doses of 5 mg BD with careful monitoring of the blood counts. This needs to be kept in mind. In patients with very high risk disease and patients who have significant increase in the blast percentage at baseline, over a period of time, all these cytopenias, one always needs to be careful whether this could be attributed to disease progression or progression to acute myeloid leukemia. And in those patients, one might want to consider a bone marrow study also. Um, Another interesting thing that they found with respect to the dose interruption and the symptoms related to myelofibrosis was that those who had this dose interruptions had also recurrence of their other constitutional symptoms and symptoms related to splenomegaly when the drug was interrupted. So prolonged interruption of the drug is not highly recommended. Now, so that was what we saw about. So patients who have more than 1 lakh counts to begin with, there is an expected fall in hemoglobin for the first 12 weeks, which usually recovers within week 24. There is an expected decline in the hemoglobin in the first 12 weeks, which declines, and then there is a stabilization of the platelet count, which needs to be monitored with time. Now, moving on to patients who have thrombocytopenia to begin with. Like we saw that in the initial comfort study, there was not the patients who had platelets of less than 1 lakh were not included. So patients who had platelet count of 50,000 to 1 lakh were later studied in various settings, and usually the most commonly the study 258 expand and the jump trial. So these were 3 trials that looked at studying these patients with platelet counts of 50,000 to 1 lakh, and to see how doses could be optimized in these patients and how ruxolitinib could be optimized in these patients. So the study 258 used a starting dose of 5 mg BD and with intrapatient dose escalation with time. And the expand evaluated different starting doses to see how this could impact. The jump was later the post-marketing, the phase 3B study expanded access trial. And unlike in the comfort study, the jump trial also included patients who were 50,000 to 1 lakh, though the cohort of patients who had 50,000 to 1 lakh was of course much lesser compared to the entire cohort. So in the so-called study 258, so the initial doses of 5 mg BD were used with gradual, increases in doses. So 5 mg, 10 mg, and then 10 mg twice daily, 10 mg, 15 mg, and 15 mg twice daily, based on monitoring. So I think this is probably a strategy that one can use even otherwise, though it is not the label strategy that is used in patients even with more than 1 lakh, where it's usually said that one should increase by 5 mg twice daily as the dose escalation. But probably using this 5 mg, 10 mg, 10 mg, 15 mg are strategies that one can use even otherwise in patients even who do not have a platelet count of less than 1 lakh is something to remember. So what was noted in the study 258 trial was that patients who completed at least the 6 weeks of therapy had optimized, that is, the dose was optimized by around 24 weeks, that is around 6 months of therapy, sorry, not 6 weeks. And the ruxolitinib significantly helped in improving the spleen volume as well as the total symptom score, which has been the main target in all these trials, that is the reduction in spleen volume and in the total symptom score. So the utilization of ruxolitinib, even in this patient with low platelet count, there was significant benefit. Also, uh, uh, that those who had this was comparable to those in patients who had higher platelet count. So this is again that there was an improvement in the quality of life. So this was the non-hematologic adverse events. So there were minimal grade 3 or grade 4 toxicities with ruxolitinib in this setting too, where I mean many times some of the concerns is with respect to infections. However, there was no significant increase in the risk of infections in these patients. With respect to the platelet count, the mean patients or the changes in the platelet counts were it was comparable to patients who had received placebo in the Comfort 1 study. So if we take this as the patients who received ruxolitinib in the Comfort 1 study, like we saw previously, there is usually an initial decline which stabilizes over time, whereas in the placebo, it remains stable. So here, the changes in the platelet count were comparable to those who had received uh, 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 the placebo ruxolitinib at lower doses. So meaning to say that there is an achievement of spleen, there is a spleen reduction, there is a control of symptoms, but not much significant thrombocytopenia in this patient, that it remains stable. Similarly, even with respect to the hemoglobin, we see that in the Comfort 1 study, like we saw, that there is an initial decline in the hemoglobin, which later improves. In these patients with low platelet count, what was seen in study 258 was that there is not significant decline in the hemoglobin at the lower doses, and that is also manageable. So that was study which showed that patients who had low platelet count also ruxolitinib 5 mg BD and with dose escalation with monitoring is a feasible strategy in these patients. More so, I think, in the current situation where we do not have access to other frontline therapies which are being approved in patients with low platelet count, like pacritinib. So in that setting, I think this, especially at least in those who have like 50 to 1 lakh, I think this using these lower doses uh, is a good option. Similarly, here, this was the JUMP trial, which was the phase 3B expanded study, where unlike in the Comfort, they did include patients who had a platelet count of 50 to 1 lakh. And they did find that the a dose escalation was feasible in at least 20% of patients, whereas the remaining required doses of around 5 mg BD to continue with. The expected adverse effects of thrombocytopenia and anemia were seen, but however, there was decline in the splenomegaly, and there were symptom responses noted even in this low cohort patients, and in the expected range compared to the phase 3 Comfort study. That is, this 5 mg BD could be used in these patients with low platelet count with a benefit on the constitutional symptoms and splenomegaly. And although there were important differences in the patient population, which may have led to a little difference in the patient outcomes, that is compared to Comfort and JUMP, the rates of response observed in the overall JUMP population was higher in those observed in the low platelet cohort, which is probably due to a difference in the doses that the patients received. Uh, Similarly, the last one, so that was study and JUMP. Then the expand was a phase 1B in patients who had 50 to 1 lakh. This again showed similar efficacy where most patients were still receiving ruxolitinib treatment. And thrombocytopenia, though required, was the most reported adverse effect and required dose interruption. And it was the only dose limiting toxicity reported. But a feasible option in patients who had platelet count of 1 lakh, and it did provide a benefit with respect to decrease in spleen size and decrease in symptom. So uh, moving on, lastly, I think on regarding the management of anemia in these patients, I think we have another lecture in some time regarding the same. So the realized study included patients who had myelofibrosis, splenomegaly, and who had anemia to begin with platelet count of more than 1 lakh. So in this specific population, where ruxolitinib was used with titration based on the platelet count monitoring. And what was looked at is the decrease in the splenomegaly size, with secondary endpoints being transfusion requirements and other safety parameters. So in this group also there was a more than 50% reduction in splenomegaly, and and most of this patients had the response by 6 months, that is at around week 24, and which was later sustained over a period of time. Even with respect to patient-related outcomes assessed using various scores. So there was significant improvement in the patient-reported outcomes calculated by either by PGIC or the TSS score or the MF-SAF score. So all of this, there was improvement in the constitutional symptoms. With respect to safety, so they were expected, adverse effects reported in all patients, with being anemia and thrombocytopenia being the most common one. However, with no significant grade 3 or grade 4 adverse events. So, I mean, I think overall, I think we would agree that the main role of JAK inhibitors would be in the control of splenomegaly and in the control of constitutional symptoms. So that is where they play a significant role. What becomes important is optimizing doses of the ruxolitinib, or the which based on the monitoring of the CBC. One needs to be wary of the decline in the hemoglobin and platelets in the initial 3 months, which is an expected adverse effect. And optimization of the dose is very essential to improve outcomes and improve symptom relief without avoiding too many interruptions for these patients. So I think still we have access to other JAK inhibitors, which is probably going to be a long time, and probably access to JAK inhibitors which will be affordable for a lot of our patients. I think ruxolitinib still remains the only drug. And playing around with this drug becomes very important to help these patients with myelofibrosis. So, so this is the dose recommendation. Okay, fine. That's it. So I think I'm done. Thank you, Dr. Murthy.
Thank you, Dr. Alok Shetty. That was wonderful, fantastic. And I request now all our discussants to please put the hand raise signs so that we can start our question answer session with Dr. Alok Shetty. Dr. Alok, can you please unshare your screen? Yeah. Perfect. Yes, Dr. Rama, your question, please.
Thank you. Hi, sir.
Hi.
You are telling ruxolitinib will be given for myelofibrosis, right? So is it given for both primary and secondary myelofibrosis with the same dosage?
Yeah, it's approved for both even post PV and post ET myelofibrosis, that is secondary myelofibrosis, and dosing recommendations would be the same for both.
Okay, thank you, sir.
Yeah. Any other question? Anybody else? So,
And what are the other JAK inhibitors which are approved right now other than the ruxolitinib?
Yeah, so first line there is ruxolitinib and fedratinib, and pacritinib in patients who have low platelet count. And there is also momelotinib, which can be used in patients who have failed on these first-line JAK inhibitors. So I think there are 4, ruxolitinib, pacritinib, momelotinib, and fedratinib.
Okay, all are approved and
All these are approved, yes. But I think we do not have, to the best of my knowledge, we do not have access to anything other than ruxolitinib.
Okay, okay.
one question has come from Dr. Aditi Goyal. Would you recommend going on fedratinib if the patient has got acute pancreatitis due to Jakavi?
I think if the I'm not sure if pancreatitis is commonly reported with ruxolitinib. So it would be, I think, difficult to prove that the pancreatitis is because of ruxolitinib per se. If you definitely feel that it is related, then probably a change of the JAK inhibitor would be recommended. I mean, just like any other grade 3 or 4 toxicity. Yeah.
True. What is the lowest dose which is important for ruxolitinib? Uh, Below that, we must not prescribe to the patient.
Yeah. So I think the lowest is 5 mg BD is the lowest dose. But I think, though many times I think we are forced by, or we try to give this 5 mg BD because of financial constraints. But unfortunately, just continuing that, just that the data shows that that is not optimum. And if you need to optimize the doses, if the patients are tolerating it. So 5 mg BD is the lowest dose, but it's not a standard recommendation to just go continue that in patients. If they're tolerating it well, the dose will need to be escalated.
Any experience using the dose of just 5 milligram OD once daily?
I have, I don't know. I don't think any of at the lowest dose I've gone to is 5 mg BD. Maybe one can use it. I've not, it's not a standard recommendation. I have not used 5 mg OD. I mean, though I've used things like, like escalating doses, sometimes we go with 10 mg, 5 mg, 10 mg, 15 mg. That can be done. Yeah.
Perfect. So, anybody else, any other question? Well, so there are no more hand-raised signs and no more questions in the chat box. Well, Dr. Alok Shetty, thank you so much for the wonderful lecture.
Yeah.
And you can stay over here because we have got another next half an hour left for the next lecture to start.
Yeah.
So we'll take a break.
Yeah.
And Dr. Nazima Kankat will join within just half an hour.
Yeah. Yeah.
Yeah. Thank you.
Thank you
Yeah.
so much.
And we have no other than Dr. Nazima Gangat from Mayo Clinic, Rochester, USA. And we have heard her excellent lectures many of times. She's again joined us. She doesn't require any introduction, but it's my formal duty to introduce Dr. Nazima Gangat. She is Professor of Medicine, Division of Hematology at the Mayo Clinic, Rochester, Minnesota. She received her medical degree from Aga Khan University, Karachi, followed by internal medicine and hematology training at Mayo Clinic before joining as faculty in 2012. She currently serves as the Education Chair, Division of Hematology and Program Director for the Advanced Hematology Fellowship Program. She was named Teacher of the Year by the Hematology Fellows in 2016, 2020, and 2021. Her clinical and research interests are focused on myeloproliferative neoplasms. She has authored as well as co-authored over 100 papers. Her key contributions to the MPN field include improving prognostication, investigating the connection between mutations and clinical phenotype, and evaluating novel therapeutics. She has served as editor-in-chief of the American Society of Hematology News Daily from 2020 to 2021. She is currently associate editor for the Blood Cancer Journal and editorial board member of the American Journal of Hematology. Today she is with us and she is going to lecture us on targeting anemia in myelodysplastic syndromes and myelofibrosis. I thank you so much. I stop over here. Over to you, Dr. Nazima Gangat.
Well, thank you so much for having me every year. So yeah, it's been a couple of years since I've been on this forum. I'm going to try to pull my screen and see if I can. Yeah, I found my PowerPoint. So we'll go ahead and discuss anemia because it's a topic that's very timely because there are several new drugs in development for anemia related to both MDS and MPN. And as you know, anemia is a common feature of both diseases, so hence I'm tackling both of them in one lecture. We'll go ahead and get started. And first of all, we need to understand what is anemia. So the definitions of anemia can be highly variable, and then kind of go through some of the newer anemia response criteria because all the clinical trials that led to the anemia drug approvals have used different parameters for defining anemia and for defining anemia response. Then review the mechanisms contributing to anemia. The main pathway that's involved is the TGF-beta BMP SMAD signaling pathway, so we can briefly review that in the clinical context. And then look through some of the newer drugs, the luspatercept, imetelstat, momelotinib, which was approved for myelofibrosis, and a few of the key clinical trials of drugs which may potentially make it to the market in the future. One of them is elritercept, which is a luspatercept counterpart, and then this 0974, which is an anti-hemojuvelin antibody-based therapy. So we'll kind of go through each of these sections in detail. So why are we talking about anemia? Anemia is very common. I do not want to belabor the point, and it is a poor prognostic indicator. It is a component of all of the prognostic scores. In myelofibrosis, it's part of the DIPS plus, the MIPS, whichever version you use. And then for MDS as well, it is part of your IPSSR. So as you can see here, half of the patients with MF have anemia at diagnosis. And by the time you go to greater than 1 year, 2/3 will have anemia. So the majority will be suffering from some form of anemia. And the anemia can be stratified by the degree of anemia. There's mild anemia. So just because somebody is 11 or 12 grams per deciliter doesn't mean that hemoglobin is okay. Hemoglobin greater than 10, but below the sex-suggested lower limit of normal. So I think it's good to also look at anemia in the context of gender because the reference range for male and females is different in every country. And then moderate anemia is hemoglobin 8 to less than 10 grams per deciliter, and the severe anemia is transfusion-dependent anemia or hemoglobin below 8 grams per deciliter. So depending on the degree of anemia, the prognosis is quite variable, ranging from about 5 years for mild anemia to about 2 years for severe anemia. And then, of course, patients with transfusion-dependent anemia have shortened survival. Similarly, in myelodysplastic syndrome, anemia needs to be evaluated in the context of the different genders and in terms of this degree of severity. So if somebody's hemoglobin is less than 9 grams per deciliter and they're males, the risk for death is much higher than if it's between 9 and 11, and greater than 11 is different. Similarly, for females, the threshold is hemoglobin below 8, and between 8 and 12, and then greater than 12. So for myelofibrosis, the criteria for defining anemia and the response assessment was recently modified last year because the previous criteria was quite old and the definitions have all changed. The threshold for transfusions have changed. Typically in the United States, we transfuse patients when the hemoglobin is below 7 gram per deciliter. But we go patient by patient. If somebody is symptomatic at 7.5, we may set that as a threshold, or if below 8, they get symptomatic. But typically, we try to keep 7 as the threshold for transfusion. So it is proposed in this proposal that the hemoglobin cutoffs for treatment or clinical trial inclusion be lowered to hemoglobin below 11 gram per deciliter for men and below 10 for females, because the thresholds we use currently are roughly below 10 gram per deciliter, and that may actually be very, very conservative, and patients can be quite symptomatic, and the later you treat the anemia, the more difficult it is to achieve response, particularly if you wait till a patient becomes transfusion dependent. Then for transfusion-dependent anemia, it said that 3 or more units in 3 months is defined as transfusion-dependent, and high transfusion burden is greater than 6 units in the prior 12 weeks. And then the baseline hemoglobin is also defined as how do we assess that. So in a transfusion-dependent patient, it would be the average of the pre-transfusion hemoglobin levels. And for the non-transfusion-dependent patients, an average of the lowest 3 hemoglobins in the last 3 months, including 1 value in the last month. So if we follow some of these criteria, then it is easier to cross-compare drugs. Otherwise, the response data and what the trials, which kind of patients the trial included, is all very heterogeneous for all of the drugs that we're going to discuss today. And then moving on to the response criteria. So for myelofibrosis, the new response criteria is for transfusion-dependent patients. Major response means no transfusions in 12 weeks and average hemoglobin increase by greater than 1.5 gram per deciliter from the baseline. And for some criteria, like the Gale criteria, does not have a minimum hemoglobin requirement. So it just stops at no transfusions needed over the last 12 weeks. And a minor response is a greater than 50% reduction in transfusion burden. The problems with some of these criteria is, once again, like we talked about, as the trials are using heterogeneous criteria, the comparison becomes difficult. And if you don't have a minimum hemoglobin cutoff, then how patients, it's easy to achieve a hemoglobin right above 7. And then you may say the patients have responded. And 7 is quite a delicate value. For some patients, they can be quite symptomatic. And the important thing is to keep your transfusion parameters more consistent before you're assessing pre-treatment and then after treatment. For example, if patients were transfused for 7 before, then they should not get transfused if they're 7.5 now. But it can vary in real practice because we want to treat the patient and not necessarily the lab values. For non-transfusion dependent patients, 12-week average hemoglobin increment of greater than 1.5 gram per deciliter from baseline, and a minor response is at least a 1 gram improvement in hemoglobin. For MDS, the criteria were put forth in 2018, so a few years back. Hemoglobin cutoff for trial inclusion was felt to be below 10. And then they also divided low transfusion burden and high transfusion burden. The definitions are once again a little bit different. They use 6 weeks as the period in which they assessed how much transfusions patients had received. So about 3 to 7 units constitutes low transfusion burden and above 8 units high transfusion burden. And non-transfusion means no transfusions in the prior 16 weeks. And baseline hemoglobin is a mean of all hemoglobin values that are available during the prior 16 weeks. And then the criteria for the transfusion-dependent responses and the non-transfusion-dependent responses are highlighted here. So once again, hemoglobin increment greater than 1.5 gram per deciliter, but it should be sustained for at least 16 weeks as opposed to the 12 weeks that was put forth in the myelofibrosis proposal. And for transfusion-dependent patients, absence of transfusions for at least 16 weeks. And the minor response is at least 50% reduction in transfusions from before when you started the medication. So after we've kind of reviewed the definitions and some of the response criteria, the key question is, why do these patients get anemia? So the mechanisms are quite diverse, and hence the management of anemia still continues to be an unmet need. So the main thing in MF is at least patients have high degree of inflammation. So there's release of pro-inflammatory cytokines, IL-1, IL-6, TNF-alpha. there is a major component of iron-restricted erythropoiesis with increase in hepcidin levels. And we'll go through this BMP SMAD signaling pathway in detail. And then in MDS, primarily, there's ineffective erythropoiesis with increase in the early stage erythroblasts and apoptosis of the late stage erythroblasts. So there is like maturation issues with erythroblasts, and that's what's the primary cause of anemia in MDS-RS in particular. And then for MF, there's splenomegaly, which leads to sequestration. There's use of JAK inhibitors such as Ruxolitinib. There's, of course, production issues. There's inappropriately reduced EPO levels and reduced production. And then there can be a component of hemolysis related to the ineffective erythropoiesis. So this slide kind of tells you that anemia management is quite tricky because in a patient, it's hard to know what is the major mechanism of anemia unless you do biomarker assessments and try to see, is my patient anemic because of high hepcidin, or is it more of an ineffective erythropoiesis element going on? You always want to rule out bleeding, iron deficiency, vitamin B12 folate deficiency. That's low-hanging fruit. Just because a patient has a myeloid malignancy, we shouldn't attribute the anemia to that. Oh, I think I probably clicked on something and now there's a big mark on my slides. I'm sorry about that. Probably a highlighter or something. I don't know if I can get rid of it. Maybe not, but I'll just keep going on. So here's the TGF-beta BMP SMAD signaling pathway. And I don't want to make it appear complicated, but it is a very complicated pathway. And this illustration is actually a simplistic one. So there are all these TGF-beta superfamily ligands floating around called TGF, activins, BMPs, GDFs. And then there are the receptors, right? So that's a receptor which also has many components. There's a type 1 receptor, which is the activin-like kinases, and then there's the type 2 receptors. So when you have TGF-beta ligand traps, such as luspatercept or sotatercept, they kind of engage with these receptors and then initiate a cascade of signaling. There's nuclear transcription factors, such as the SMADs floating around. They form a complex with SMAD4 and then translocate to the nucleus, and they can cause deregulation of late-stage erythropoiesis. So that is the mechanism by which luspatercept works. It's a TGF-beta ligand trap, an activin receptor type 2B ligand trap. So it was functioning through this pathway primarily on the left-hand side of the slide. And then there are other treatments such as momelotinib, which is an activin-like receptor kinase ACVR1 inhibitor. And that is acting on the other side of the pathway, which is primarily dealing with SMAD1, 5, and 8. And it leads to increase in hepcidin if there is no inhibitor. But if you have an inhibitor, the hepcidin levels go down and help with the iron-restricted erythropoiesis. And then there are other therapies under development, which we will review, such as the anti-hemojuvelin antibody, which directly inhibits hemojuvelin. So in essence, you're reducing hepcidin levels. And in the corner of this slide, I also have the HIF pathway, because that is pretty important in EPO production. And there are HIF inhibitors which are in development for chronic kidney disease. They were trialed in MDS, not very successful though in MDS based on the phase 3 data. So if you inhibit the HIF-PHT pathway, you're going to have increase in EPO, because typically when PHT hydroxylates HIF, it leads to its degradation. So when you inhibit PHT, there's increase in HIF and increase in EPO levels, which indirectly will reduce your hepcidin. And that can also ameliorate the anemia related to iron-restricted erythropoiesis. So we want to think about these pathways happening in parallel. For some patients, it's the deregulation of late-stage erythropoiesis, which is the main element, such as an MDS-RS. And for myelofibrosis patients, it's increase in hepcidin, which is a key feature of their anemia. And there can be a mixed picture as well, but that is how these drugs work. So luspatercept is working as a TGF-beta ligand trap on this side of the pathway, SMAD2/3, and then the momelotinib is working on the other side. ACVR1 inhibition inhibits SMAD1, 5, and 8 and reduces hepcidin levels. And then there are newer therapies being developed for each of these areas. Oh, let's see. Oh, my slides did stop now. Maybe I need to. Okay, we can move to the next one. So what are the therapeutic options for anemia and myelofibrosis? So we have some conventional therapies available, which I have listed here. If there's anemia without splenomegaly, typically you look at the EPO level. And sorry, my 200 just got erased too. So if EPO is below 200, then ESAs may be used. I usually use 200 rather than 500 as the cutoff. There's androgens, particularly danazol, can be used. Then there are the older drugs, thalidomide, prednisone, and lenalidomide, because in MF, there's not much 5Q, so I don't use much lenalidomide for the anemia related to myelofibrosis. Then if anemia is accompanied by splenomegaly or symptoms, then you have momelotinib, which is approved treatment. You can use ruxolitinib, but that makes anemia worse. So there is a possibility of combining the ruxolitinib with ESA-based therapy, or even off-label luspatercept sometimes, depending on the situation. And if all the drugs are failing, then splenectomy needs to be considered, because that will take care of the splenomegaly as well as severe anemia, particularly if there's transfusion-dependent anemia. So what are the therapeutic options for anemia and low-risk MDS? ESAs, if EPO below 200, there's luspatercept, which is approved for both MDSRS and non-MDSRS. Imetelstat is also an approved drug, but I use it sparingly and for reasons that we will discuss later. And then you can sometimes use low-dose hypomethylating agent like decitabine for 3 days as well, if the other medications are failing. And for MDS5Q, lenalidomide is the approved treatment and a very effective treatment. And then I had gone through the TGF-beta pathway. So these are all the inhibitors listed here. There are the TGF-beta ligand traps, which we discussed. Luspatercept is an approved agent, and I'm sure you guys are familiar with it. Then there's an activin receptor 2A ligand trap in development called elritercept, which we will discuss. So sotatercept is no longer being developed. It is approved for pulmonary arterial hypertension, though. And then the ACVR1 inhibitor and the JAK2 inhibitor, momelotinib, for myelofibrosis. And then a treatment which reduces hepcidin is an antihemojuvelin antibody, the DIS-0974. It doesn't have a name yet because it's in phase 2 clinical trials right now. So the data for the luspatercept, since it's an approved drug, I don't want to go through all the data, but I did summarize the key trials, the MEDALIST study and the COMMAND study, which compared luspatercept with placebo versus luspatercept versus ESA. And you saw that the response rates were higher with luspatercept in MDSRS patients in particular. But the indication has been expanded to include frontline use in all kinds of MDS, irrespective of the presence of ring sideroblasts. And it does have a few side effects listed below, some dizziness, some pain, hypertension. So none of these drugs come with no side effects, but a relatively well-tolerated agent. It's given subcutaneous every 3 weeks, and there's a dose titration. Starts with 1 mg per kg, and then you up titrate to 1.33 and then 1.75 mg per kg. So it has been a big advance in MDSRS in particular, and it works nicely, as you can see from the phase 3 data. So elritercept is a sister drug to luspatercept, which is under development in low-risk MDS. It's moved to phase 3 study, which is ongoing right now. It's also given sub-Q. It's given every 4 weeks. The transfusion independent rate in the phase 2 study was 42%, and it actually worked better for patients without ring sideroblasts, which is a good thing because we already have a good drug for MDS with ring sideroblasts. Fortunately, it also had an impact on platelet count, and there was a platelet count increase that was noted, which can be a valuable side effects in patients with MDS who potentially have low platelets as well, some of them. And then here are the side effects listed, which was nothing out of the ordinary. A few symptoms here and there, some diarrhea, nausea, headache, and fatigue, which is very hard to evaluate in these patients. And then imetelstat is a telomerase inhibitor, which is approved for low-risk MDS with relapse or refractory to ESA therapy. It is an IV infusion. And as you can see from the phase 3 and the phase 2 data, the transfusion-independent rates were much higher with imetelstat versus placebo. And the grade 3 neutropenia and thrombocytopenia rates are quite impressive, like 2/3 of patients experience that. So hence I use imetelstat quite sparingly and literally as a later line of therapy rather than frontline therapy for sure. Because these are low-risk MDS patients and they do not need to suffer from neutropenia necessarily and thrombocytopenia. So anemia and myelofibrosis continues to be an unmet need because most of the trials in myelofibrosis are focused on spleen response. And there are very few drugs that are specifically approved for anemia. Momelotinib is the only one And then we are borrowing drugs, right? ESA is not approved, danazol is not approved, but we extrapolate and use it in anemic patients. So I'm not going to read this whole slide, but it tells you that anemia is, of course, a poor prognostic indicator. It shortens life. It worsens your quality of life as well. And we only have the momelotinib, and momelotinib is not specific for anemia. So it's a drug used to treat myelofibrosis in patients who are anemic. So it's mostly a spleen and a symptom drug. And we will go through the data of the MOMENTUM study, which led to its approval, where momelotinib was compared to danazol in anemic patients previously having received JAK inhibitor. And compared to danazol, you saw that there was non-inferiority. The transfusion-independent rates were higher with momelotinib compared to danazol, which was not surprising. And as you can see, it does cause thrombocytopenia, momelotinib, and grade 3 infections were similar in the two arms, and peripheral neuropathy is a side effect of momelotinib as well. And the more I'm using it in practice, I've encountered a few patients who develop it for no other good reason but the momelotinib use. So once again, the MOMENTUM trial, it actually showed superiority in terms of spleen and symptom response compared to danazol, which was not surprising at all because danazol is not a spleen drug. And then here in a graphic form, the transfusion independence rates at week 24 were non-inferior between momelotinib and danazol. So where is luspatercept in MF development? It is phase 3 study has been completed. And the phase 2 data actually was quite modest. It was not as impressive as it was in MDSRS. So we know the mechanism of luspatercept. It is an erythropoiesis maturation agent. And as you can see here, it was studied in non-transfusion dependent and transfusion dependent patients, and with Ruxo and without Ruxo. And in transfusion dependent patients on ruxolitinib, the in response rates were about 26%. So very modest response rates. And the phase 3 data is awaited, and hopefully it might be released later this year. So we will know whether luspatercept is going to be approved. Where right now we are able to use it off-label because it is on the market for MDS. So if a patient has SF3B1 and MF, or if they have ring sideroblasts, they are often unable to get it without any issues with insurance. So moving on to some of the newer therapies, particularly the anti-hemojuvelin antibody. We talked about hepcidin being a key driver of anemia and myelofibrosis. The levels are considerably higher in patients with MF compared to controls, and it depends on the severity of anemia. So the more severe the anemia, typically the higher the hepcidin levels. And the etiology of anemia and MF is multifactorial, like we reviewed in the slides, a few slides earlier. And it continues to be an unmet need. We have several agents targeting the TGF-beta SMAD pathway under investigation, including elritercept. Elritercept is also in phase 2 studies for MF, like it is moved on to phase 3 for MDS, which is a similar drug to luspatercept. So what is DIS-0974? It's a monoclonal antibody against hemojuvelin, which blocks BMP SMAD signaling, reduces hepcidin, increases intestinal absorption of iron, increases the mobilization of iron into the circulation, and improves anemia. So it has been studied in a phase 1b setting. The data was presented at ASH last year. So 35 patients treated, and there was a 75% reduction in serum hepcidin, nice mobilization of iron, increased reticulocyte hemoglobin, and improvement in hemoglobins were noted in the majority of the patients. So here is the data for the non-transfusion dependent patients. Overall response rate in 59% of the patients, which met the criteria for response as we had reviewed earlier. Major responses were in about half of the patients, and there was improvement in the fatigue score as well. Impressively, the time to first response was within 1 to 2 months, which is quite impressive, and the duration of response is quite high, and patients are continuing to respond even 2 years into treatment. And similarly, for transfusion-dependent low patients, the response rates were quite impressive. 100% of patients had a 50% reduction in transfusions, and 80% had met the criteria for major response. There were few high TD patients, but once again, the data is inconsistent with the other categories of anemia. What about sodium glucose cotransporter inhibitors? We have these medicines available for heart failure, diabetes, and they are known to cause erythrocytosis. So we looked at it in a small cohort of MDS patients, 9 patients, and about 2/3 had a hemoglobin increase of 1 gram per deciliter after starting treatment. A third had a hemoglobin increase of 1.5 grams. And only a few of these patients were on other treatments, but those treatments were not working for those patients. That's why they were starting on the SGLT inhibitor, but the indication for the SGLT use was another indication like diabetes or heart failure or chronic kidney disease. So there is some hope that this may be developed and used off-label in myeloid malignancies, so we can gather some data whether it actually has erythropoietic activity. Similarly, in myelofibrosis, there were 16 patients that we have treated, and about a third of them have had an hemoglobin increase of 1.5 gram per deciliter. And about 83% of patients with severe anemia with hemoglobin below 10 showed improvement of at least 1 gram. So I know some of these patients are on other treatments as well, so the report results can be confounded, but something to keep in mind for the future. So what's my take-home message here? For the pathogenetic mechanisms, they are quite diverse. The TGF-beta BMP SMAD signaling pathway is being targeted by the newer agents. There's your iron-restricted erythropoiesis with increase in hepcidin. And then there's ineffective erythropoiesis. They are driven by different parts of the TGF-beta pathway. And then there are other causes of anemia as listed below. The key point is to treat anemia early. I think we wait too long before patients become transfusion dependent. So if you treat anemia early, there's a higher chances of preventing transfusion needs and also improving the anemia faster. We have approved agents listed here, and we have several investigational agents. And then we have several combination therapies which are undergoing testing, luspatercept plus ESA, luspatercept plus Revlimid, and then a couple of drugs are being combined with momelotinib in myelofibrosis to see if we can augment anemia responses. So there's a lot of interest in developing combination therapies, which makes sense because they have different mechanisms of action. And everything that I presented today is covered in this review paper that I prepared earlier this year, and it's published in the American Journal of Hematology. So that's kind of a reference to leave you guys with. So thank you for your time, and I'll take all your questions now.
Thank you, Dr. Nazima Gangat, for the fantastic lecture, as always. Always worth to listen to you. No doubt you are a very good teacher. Thanks a lot. And I now request all our discussants to please put the hand raise sign so that we can start our question answer session with Dr. Nazima Gangat. Dr. Nazima, can you please unshare your screen so that we can see it?
Okay, yeah. Is this better?
Yes, thank you. Dr. Satish, your question.
Thank you, Dr. Nazima, for that concise and wonderful presentation. Good to know all the new things, what is happening, though we don't have access to many of those drugs. But erythropoietin, luspatercept are available in India. So my first basic question is, how do you sequence, like for anemia, what in MF and MDS, how do you sequence treatment with ESA or luspatercept or other agents right now, Dr. Nazima?
So for MDS, I usually use ESA first if EPO is below 200. So if it's an MDS-RS patient, I don't go to luspatercept as first line, even though it has been approved for first line use as well. And then depending on the response, I switch to luspatercept. But there is also data now emerging that you can combine the two agents if you have suboptimal response. For example, if somebody is on luspatercept and not working, and if the EPO is suboptimal, you can add an ESA and see if you can augment the response. And at least in retrospective studies, about 30% of patients have been able to achieve a response in that fashion too. For myelofibrosis, I'd look at what is the main problem. For example, if somebody doesn't have a spleen issue or symptom issue, then I think you have to go back to the drawing board and use more traditional treatments for anemia rather than JAK inhibitors. If somebody has an enlarged spleen or symptoms, then you can make a case for momelotinib use. But otherwise, just for anemia alone, I do not use momelotinib because it has side effects.
Right. So I have a patient, low-risk MDS with SF3B1 mutation, whom we started with luspatercept, started with 1 milligram and then went to, because she didn't respond, went up to 1.75 milligram per kg. And it's almost 4 doses now, once in 3 weeks. So she has not shown any response. She's still requiring around 2 transfusions every month. So are there any predictors of response? And I see that only 40% of them respond. So any predictors of response, Dr. Nazima? And if they respond, what is the durability of response? Third question is, if they don't respond, how do you treat those patients, the MDS with SF3B1?
So the predictors of response, like I said, they are not very well characterized. There are some retrospective data on predictors of response. It depends on the EPO level as well. What is your patient's EPO level, by the way? Do you have the EPO
I
level
think
for
it
your
was
patient?
around 400 or 350. I'm not remembering, but
So
it
it
was
was a
around
high,
that.
so it was a high EPO level. So then patients with lower EPO tend to respond because they're going to respond to anything. If somebody's EPO level is high, then you know that ESA is not going to be an option for them. So I don't think we have like clear outline predictors. There are some studies here and there, but none of the data is like more consistent. So I wouldn't go by like, we don't have good biomarkers of response. But if you don't have that and your patient is in this situation, I think it may be time to move on to a different therapy, right? If we think they're not responding. And the treatments I use before I go to imetelstat, I think imetelstat is not available in your country. I would use low dose decitabine, 3 days of decitabine, because if it's severe anemia and it's not improving with luspatercept and it's not going to be amenable to ESA therapy, it is reasonable to do HMA therapy.
Have such patients anytime responded to thal, prednisolone, or anything? Have you tried, Dr. Naseem?
I don't use it that much for MDS, but I have used it sometimes for MF, but it's an old drug. So you know how we always feel like you can always try it if it's available easily in your country. It doesn't have much side effects. Thalpred actually is pretty decently tolerated in the times I've used it. I don't have much data, and you could always do androgens too. You could try danazol. I think anything is fair game. But I think for MDS, at least the data for the low dose HMA use is better, especially if the severe anemia not responsive to other treatments.
Okay. Thank you so much, Dr. Naseem. Thank you.
I think there's a question in the chat box. Your management of elderly MF with non-palpable splenomegaly, your management for MF when not feasible JAK inhibitor. So I'm presuming this is about anemia, right? So if an anemic MF patient doesn't have a big spleen and we don't want to use JAK inhibitor, then usually I will start with the basic drugs like danazol or ESA, depending on the EPO level. And then we can even use drugs like Thalpred. So not every MF patient needs a JAK inhibitor, especially the Ruxolitinib use has been known to exacerbate anemia. So if somebody has borderline hemoglobin and you start them on Ruxolitinib, you can only make them transfusion dependent. So we have to be very careful. And that's why Ruxolitinib has to be sometimes combined with ESA or other anemia drugs. And, you know, now the data for the DIS0974 with the Ruxolitinib is actually very impressive. And we'll have more data at the ASH meeting this year. And hopefully it will move to a phase 3 study and then reach globally, right?
True. Dr. Nazima, from the question what Dr. Satish had asked regarding the patient has failed erythropoietin, patient has failed luspatercept in the case of SF3B1 mutation. Before jumping to HMA, can we first try with LEN and then jump to HMA, or directly we can go to HMA?
I mean, I think it depends on what you and the patient decide, right? Revlimid has advantage, it's a pill. So some patients may like taking a pill, but the response rate for non-5q MDS and Revlimid is not the best either, right? Response rate, I mean, it's non-5q MDS. We're talking about MDSRS. I don't think there's nothing wrong. You know, you can try the Revlimid, and there's also oral form of HMA, right? The oral dacogen. That can be used as well if the IV is an issue for the patient. So there are a couple of ways to do it. I'm okay. There are situations when I go directly to the HMA, and I think in the non-5q MDS and MF, I tend to not use that much Revlimid because I haven't had good success.
Thank you. Dr. Alok Shetty, your question?
Yeah, hi. This luspatercept, do you feel there's any benefit with respect to spleen? Because we had one patient who were giving luspatercept. He actually responded to the escalated dose, and I feel over time his spleen, he had like significant hepatosplenomegaly to begin with. And that, I mean, not too symptomatic initially, but that too seems to be regressing. I mean, is that something that is seen as something I was curious? And another question I had was, how many of your patients go in for splenomegaly, and what challenges do you face post splenomegaly?
Means splenectomy?
Splenectomy, sorry, splenectomy.
Yes,
sorry.
yes.
Yeah,
So
yeah.
let me handle your luspatercept question first. So we expect the spleen. So luspatercept is not directly a spleen drug. So it's not mechanistically designed to shrink the spleen. But if you improve the anemia, your spleen is automatically indirectly going to shrink, because when you are anemic, the spleen is trying to take the job of the bone marrow. So there's extramedullary hematopoiesis. So I think I can see why your patient's spleen started shrinking when the anemia response happened, because it's kind of an indirect way rather than a direct spleen shrinking effect. And the splenectomy is used sparingly. You know, in the era of so many drugs, nobody wants to go through a big surgery because it has complication rates, particularly thrombosis and bleeding risks perioperatively are quite high with myelofibrosis splenectomies with a large spleen. We have reported on about 30 patients who were previously treated with a JAK inhibitor and underwent splenectomy. The majority of them had it as a bridge to transplant, because patients with a big spleen are usually not taken in directly for BMT because of engraftment issues. And those patients actually, more than 2/3 of those patients who had transfusion-dependent anemia responded from the anemia standpoint too. Because when you're severely anemic and you have a big spleen, even when you transfuse you, all the red cells go and live in the spleen. So it has anemia response rates when you remove the spleen. So it can have a twofold effect. Even if your patient is not going to be a transplant candidate, if they're fit enough to have a splenectomy medically, it can help with splenomegaly, plus take care of the severe transfusion-dependent anemia.
I mean, do you see like extramedullary hematopoiesis happening at other sites after splenectomy or any?
I mean, the liver typically enlarges, it becomes more palpable, but I have not necessarily seen lung EMH or anything that severe happening. We have decent follow-up data for these patients. So in the JAK inhibitor era, splenectomy is not being performed that frequently, but you'll be surprised that despite having so many JAK inhibitors, we're still having to remove spleens as a bridge to transplant in a minority of patients.
Thank you, Dr. Alok. From the same note, Dr. Nazima, can we go for partial splenectomy in any of the patients?
We don't have the experience with that in Mayo. I have not had a single patient who's had a partial splenectomy. We've had experience with spleen radiation, right? And I don't know about partial splenectomy. I can actually ask our surgeons, because I didn't even know that was a possibility, and I didn't know if is there any literature and experience from your center on that?
Some questions regarding partial splenectomy.
Okay, I would have to look up, and I can ask our surgeons if that's even a possibility.
And anything regarding splenic artery embolization?
Yes, our surgeons will often do that for IMF patients to reduce the risk of perioperative bleeding. So we will have an embolization procedure done right before the splenectomy. So that is being commonly utilized at Mayo, especially with ITP spleens as well as MF spleens when they're so large and there's risk for hemorrhage. Yep.
Thank you. There is one question from Dr. Shin Leong. How long do you try for luspatercept in low-risk MDS before you say that it's not working?
So we, of course, up titrate. In my experience, I typically, if I'm going to get a response, I usually get it with the first dose level, 1 mg per kg. And if I'm going up to 1.75, I usually give the patients like a 3-month trial on that dose. I don't like to abandon drugs very fast. And then, we say that it's not working, because if it's not working, you know it pretty clearly. Usually response data, I know we tend to sometimes look too hard, but if it's working, you know it from the trend in the hemoglobin, especially if a transfusion dependent patient, you'll know how many transfusions they're requiring. So I think a 3-month trial on the maximum dose is an appropriate trial to say if it's working or not working. And I think one of your colleagues had asked me about luspatercept duration of response. So there is duration of response reported from the Medalist study, and there were patients, a lot of patients at the 1-year mark, they had actually lost response. So that's the other things for luspatercept. I think the duration of response in practice is yet to be determined as well, because it's not like it is forever. I think Dr. Satish Kumar had asked me that question. Yeah.
Thank you, Dr. Nasim. Dr. Amit, just ask one question.
Yes, please go ahead.
So MDS without SFB1 mutation, but if they have TET2 or ASXL1 mutation, do they respond to luspatercept, Dr. Nasim, if the erythropoietin levels is very high, or these mutations, co-occurrence of these mutations confer resistance to luspatercept?
The response rates are lower. It's not like they do not respond. So it's not 0%, but as you can see, the response rates were the highest with MDSRS and lower. So I wouldn't preclude luspatercept use in those patients, because for a patient, if a medicine is going to work, it will work regardless of what biomarkers they have. And I'm not sure about the mutational correlates of luspatercept response. I haven't looked into it that closely, so I have to be honest with you here.
And do you use iron chelation if they're transfusion dependent with luspatercept? That's safe, right? We can use deferriprone.
You can use iron chelation. There is no interaction between iron chelators. That's a good question.
Thank you.
Thank you, Dr. Satish. You said about using decitabine after you fail your ESA and luspatercept. Any thought on that? Why not azacitidine rather than decitabine?
I don't have any, there's no comparative data. For me, in my practice, I prefer decitabine over azacitidine for everything. So you know how you kind of gravitate towards one medication? It's primarily because of the dosing is shorter. For AZA, it's 7 or 5 days. For low dose AZA, for this one, it's 5 or 3 days. So I have used in AML, in MDS, I tend to use decitabine as my HMA, but I know there are, especially in AML, some doctors really stick to the VIALE-A data and use azacitidine. I think both HMAs have been shown to be comparable in AML as well, and I think the same can be said about MDS. So I don't have a problem with you using azacitidine if that's easier to get in your country. But I prefer decitabine.
Thank you. Another question is from Dr. Lee B. Sun. Is there any concern of using ESA, erythropoietin stimulating agents in MDS or MF with low blast?
In terms of stimulating the blasts, is there concern?
Yes.
For MF, sometimes there is a theoretical concern you may enlarge the spleen further. So ESAs are not used very often in MF patients in general, in at least our practice at Mayo, because there is a theoretical concern that splenomegaly may worsen. In terms of stimulating the blasts, I don't have any particular concerns or any experience in saying that we make them go into a more accelerated phase or transform to AML or anything. I don't have any concern about that.
Thank you. So let me check any other question. Well, so anybody has any other question?
Sorry,
Yeah.
Dr. Narasimha. In post-polycythemia, post-PVMF, do you manage anemia differently compared to primary MF?
No, the management of anemia in secondary MF post-PVOET is the same as primary MF. The patients with post-PVMF will tend to have less anemia, right? Those patients usually are not the ones who have the severe anemia, but they can if the MF has become progressive. But it doesn't mean that we have different drugs for anemia. I think it becomes myelofibrosis,
Right. Thank you.
So there is one question regarding a patient with his 52 years male with a platelet count of 15 lakhs. That means for you
1.5 million.
1.5 million.
Okay.
And the bone marrow shows large stagnant megakaryocytes, but in clustering with grade 2 myelofibrosis. Patient is asymptomatic. How would you manage this condition?
So we're trying to manage extreme thrombocytosis.
Extreme
Is that what we're trying to
yes.
manage?
Asymptomatic, but grade 2.
I think you can, if the patient has an indication for other forms of treatment, it depends on what else the patient has. If you're just trying to treat the platelet count, I usually don't just treat the platelet count. Let it be, check for acquired von Willebrand's. If they have a bleeding phenotype or if they have reason to have acquired von Willebrand's, just avoid the aspirin use for these patients. But I wouldn't necessarily try to cytoreduce them just to bring the platelet count down if there's no other symptom going on. If they have a big spleen or something, then you could say, well, you need to treat the patient and you could use Hydrea, you could use your Ruxolitinib, because most of the JAK inhibitors have a side effect of thrombocytopenia, right? So if you use a JAK inhibitor, it will bring the platelet count down. It may help with some of the other features like symptoms of spleen. But by itself, I do not advocate for treating platelet counts. Like that's just treating lab values. And this we have shown in ET patients as well. Patients with extreme thrombocytosis is a question that comes up frequently. Young ET patient, platelet count of 2 million, 1.5 million. We tend to avoid treating them with cytoreductive drugs unless needed.
Thank you. Anybody has any other question? Well, in that case, Dr. Nazima, Dr. Satish, yes.
Just wanted to thank you so much. Thank you so much, Dr. Narasimha.
Thank you, everyone. You guys are so engaged. And anemia is, yeah, go ahead.
One question from Dr. Cixing Leong. Which type of ESA do you prefer? Whether short-acting or long-acting erythropoietin, or would you prefer darbepoetin?
Another very good question. I like the long-acting. It helps the patient. It helps me. Aranesp is my favorite, darbepoetin, 500 microgram every 21 days. But there are some insurance issues I encounter sometimes when they want me to try Procrit and Retacrit before going to Darbepoetin. So those are like weekly. And, patient has to go in. These are not self-injections. So the worst part is patient has to go in, get his hemoglobin checked, because usually there's a hold parameter, right? You want to hold ESA if hemoglobin is above 11. So it is very cumbersome for both the patient and the provider in the healthcare system. So I would prefer using long-acting rather than short-acting because the data for all of them are comparable.
Thank you. Fine. So that's all. Let's bring to the end. Dr. Nazima, again, fantastic lecture, wonderful discussion, what a wonderful learning, and above all, you are a wonderful teacher.
Thank
Thanks
you
a lot.
so much. And anemia is an evolving field, so I hope to be back on the forum in about a year or so. We may have like new drugs on the market, and they'll make it to India as well. I wouldn't be surprised because all these drugs, if luspatercept is available, elritercept seems like it will compete with luspatercept because it has the same mechanism of action and the advantage of having the platelet improvement. So I think we're going to have a lot of discussion on anemia, hopefully in the future. Okay. So this was just the beginner. This was the primer, and to keep an eye out for all these new drugs, right?
Exactly. Thank you so much. Thanks a lot.
Thank you
And
for your time. Enjoy your weekend, everyone. Thank you. Bye.
Thanks a lot. Bye-bye.